welcome everybody to today's episode of Marvelous Medicine, which is on harnessing artificial intelligence in enhancing surgical outcomes. We are very, very privileged to have Professor Mahendra Bhandari with us to be one of the moderators for the session. Dr. Bhandari is the CEO of Verticuity Foundation, Director Robotic Surgery Research and Education, Director Basic Sciences at Verticuity Urology Institute at Detroit, Michigan. He was previously the Vice Chancellor of King George University and the Director of Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Professor Bhandari is the recipient of the Padma Shri, Dr. B.C. Roy Award, and the President's Gold Medal of the Urological Society of India, among several other awards. Dr. Bhandari is the living example of age being just a number, and also that learning, we never stop learning. When he could have rested on his laurels after being a vice chancellor and receiving the Padma Shri, he decided to do a course in biostatistics at Harvard at the age of 62. And then he went on to do his MBA from Raw School of Business Management at the age of 65. And at the age of 73, he's just done a course in economics from Stanford. When most young doctors are still grappling with accepting that AI has come to stay, Professor Bhandari's current research is focused on artificial intelligence applications in urology, predicting intraoperative complications, computer vision models for kidney surgery, and the use of augmented reality, virtual reality, and mixed reality to build user-friendly interface for kidney surgery. Professor Bhandari is passionate about disruptive technologies and new robotic tools to make surgery safe, and is deeply involved in the development and dissemination of robotic surgery across the globe. He still travels across the globe, and he's just recently returned after a 3-month trip to India. Despite that, as soon as I sent a single WhatsApp message, Professor Bhandari accepted this invitation to join us and be the moderator for this session. Thank you so much, sir. Dr. Bhandari has been a big supporter of our Marvelous Medicine initiative, and I cannot thank you enough, sir.
Sorry, Vidya. Sorry, I was late. Sorry, sir.
No worries. Co-moderating the session will be the Gen Next, Dr. Adit Chinnaswamy. He's the co-founder of Medicine VR, a medtech company focusing on virtual reality simulation-based training across healthcare professionals. He's a laparoscopic surgeon at the Madras Institute of Urology with a keen interest in surgical simulators and the field of haptics. Adit did his general surgery from Sri Ramchandra Medical College and Research Institute after doing his MBBS from TNE, and he also did his fellowship in minimal access surgery from the World Laparoscopic Hospital, Delhi. Adit is trying to revolutionize healthcare education by integrating VR and AI-driven upskilling solutions. His company Medicine VR has established cutting-edge training labs across India, helping to enhance medical education and bridge the gap between theory and practice, all hopefully to improve patient outcomes. Adit has recently been on Marvelous Medicine, where his talk on AR and VR was very well appreciated. We are glad to have Dr. Shivam Natarajan, the speaker for today. He's the owner of SV Healthcare Solutions Limited, UK. He's the chief mentor of Lion Orbit Technologies and the CEO of Medverse Limited, UK. Shivam did his MBBS, MS, and DNB surgery from Jipma Pondicherry, and he's a fellow of the Royal College of Surgeons and Physicians of Glasgow. He did his postgraduate diploma in hospital management and MBA from the National Institute of Business Management. His special interests include AI in healthcare, big data platforms, clinical engagement and transformation, clinical commissioning, healthcare technology strategy, and business development strategy. He has authored 4 books and has 20 international peer-reviewed publications. He has been the advisor to the World Health Organization and the governments of India, UAE, UK, Singapore, and Malaysia. Shivam has again been a supporter of Marvelous Medicine, and whenever I've approached him, he has immediately accepted. In fact, he shared the news that he had spoken on AI in surgery, and I said immediately that he has to do something similar for Marvelous Medicine, and that's how we are on this today. Over to you, Shivam.
Thank you, Vidya, and extremely sorry I had some technical problems to log in. And before I start, I want to say what a privilege it is. I've got two of my gurus on the call. I can see Professor, is it Professor Anantharishnan there on that call? I hope so. Hello, sir. And I've got Professor Bandari. Both of you have been part of my life for about 15 years under chief, and I learned everything in my surgery from him. I'm sure he must be mildly disappointed that I am not talking about surgery as such as general surgery, but sir, I can assure you that whatever you're taught has gone a long way. And after I left that, and Professor Bandari has been my mentor for now another, I think the journey is nearly 25 years now from university days. Although Professor Bandari was there for my undergraduation days, my pleasure was starting to work with him with the Medvarsity project in India, in Apollo, Hyderabad, and from there we have had a lot of interaction. And I just thank God for giving me this privilege to be with two of my gurus, and my pranam to both of them, sirs. And thank you, Vidya, for this. Let me share this slide deck. And I just wanted to say that how we want to do this presentation is, while I'll sort of lay down some of the basics of it, I want to involve as much as possible uh, both the moderators. So I might be a moderator here rather than the presenter, if I may say so, and bring in both Aditya and Professor Bandari as it goes along. I've got quite a comprehensive set of slides. It's quite a lot of material to cover within this time. So what I will do, Vidya, is possibly skip some of them and go fast, and then also share the slide deck so you can share it with the group later on. I'm going to just put it on now. Sure. Are you able to see the slides?
Yes.
Yeah, thank you. So the how I have structured the presentation is we just recently had one of the AI discussions about a month back. Many of you might be here, so I might quickly go with. Sorry, I think it's just moving faster. Okay, I'll just sort of try to cover the basics of AI first, because some of them, I just want us all to be on the same page. AI is such a fast-moving field. It is just what even I have got a week back might be quite old. So I'll just bring us all on the common page, and then bring in some illustrations of how AI comes into the surgical field and what are the various advances that has happened. And if possible, I will cover different types of surgeries, and then possibly open it up for some discussions. My view is possibly we will pause every 15-20 minutes, or sorry, 15, maybe 10 or 15 minutes, and then see if we can enter into a discussion. And I will look forward to the moderators to push me on if we are not covering certain things. I think all of us understand about AI in very different ways, but effectively what it means is it is simulating human-like intelligence, and it does that in many ways. It can solve problems, it can make decisions, it can help our learning, it can help our understanding. It has not yet reached, in fact, it has also started reaching into the moral realm and spiritual realm. So today we talk of embodiment in AI. So literally, AI is gone from physical nature of human and also entered into the spiritual and moral realms of human. It has literally taken through every space. The AI that we talk of on a day-to-day basis is what we call as something narrow AI. And that is what is most of the AI today that you see in the world is an AI which has been configured to deal with a very specific problem and a specific task. So your chatbots or your diabetic retinopathy screening or your decision support tool or sepsis indicators, all of them are narrow AI, and that is what is the most that we see. But AI is also being matured, or people are working on what we call as general AI, which many of you would have heard. there is not still a definitely working model of general AI. What general AI is, the ability to replicate all human intellectual tasks and be able to perform it. And we have not yet reached a good example of a general AI, which is also referred to as strong AI. And it should be able to do everything that a trained doctor can do, which means, it should be able to cry as a doctor. It should be able to go to the room and say, look, I failed. At the same time, it should be able to take a decision or work in an emergency department. That level of general AI is still not reached, but people are working towards that. Many of you would have heard something like agentic AI or AI agents. There are a lot of small, narrow AI which people are bringing together. Like, I've got an AI which can talk, I've got an AI which can see, I've got an AI which can move, and people are trying to add all of that and bring it into an agentic AI. But still, that is not equal to general AI, just to give that terminology. Then the next level of AI is what we call as super AI. And super AI is going to be something beyond what human intelligence can achieve, and not just in one field, but across multiple fields. So it's like that multidisciplinary doctor who can be both the manager as well as the surgeon, as well as the public health specialist, and be a policy and economist also. We have yet to achieve super AI, and the prediction is hopefully in not, I don't know whether to use the word hopefully, but they are predicting in another, some say 5 years, some are saying 20 years, some are saying up to 60 years. Now, that is one way of looking at AI. The other way of looking at AI is, what are the different roles it does, and that is another way of looking at what all types of AI there. I'll just quickly go through this because this is the basics, and we'll all be on the same ground after that. We got rule-based systems. And we have had a lot of years of living in rule-based system, like decision support or alerts and things in your EMR. The other area has been machine learning, where lots of data is being able to be analyzed, and there is something like deep learning, where we are trying to mimic the ability of the machine to interpret, not just to analyze. So there's an analysis, there's an interpretation, and then there is a learning, and above that then comes wisdom. And we have not yet reached that wisdom, but I'm sure Professor Bandari will soon give you some examples where they're working towards that learning and wisdom. Another element of AI that is there, which is called as reproducibility. As humans, we have the ability to reproduce, and that is another dimension of AI which is growing. And they've already demonstrated that an AI can generate and create another AI without even human intervention. So I'm just giving all this as examples so that we understand that there are different levels of AI, and that there is different complexities of AI, and there is different means by which AI works. And it is up to us as human beings to know all this immense capability that exists in AI and bring it to our use. You've heard of deep learning, possibly. Deep learning uses something called as artificial neural networks, and through that, it is able to do a lot of recognition of patterns and recognition of situations and simulate scenarios, for example. So, for example, in dermatology, you've got that. So I'll quickly then move into the other place that AI is becoming integrated is what we call as robotics, where there is the intelligence part of the human and the mechanical part of the human. When they come together, then we have got robotics, which is coming in, and Prof. Bandari will be talking a lot about that soon. Great. What are the benefits of AI then? Why did we do all this? And ultimately, if you look at all the case examples that I'll be talking of when we're looking at AI in surgery, it'll be doing one of these. It'll either enhance efficiency, it'll improve our ability to make diagnostics or collate in data and bring in analysis. It can be predictive, as like our brains, I don't know whether Dr. Kate is on the, whenever I talk of predictive or AI, I think of Dr. Kate because he introduced AI when I was intern with him maybe 30 years, 35 years back. I'm sure all of you have been through night duties and emergencies, and, oh, we would have worked all through the night with a case of peritonitis or something, we would have done ultrasound, we would have done all these investigations, and we wouldn't know whether to open the abdomen or not. And a negative laparotomy is always a problem. Next day, you have to answer chief when he comes in the room, why did you do the negative? So we'll have to call the consultant or senior registrar and on call, and so we'll call and say, this is the investigation, this is the finding, this is the history, everything done. And then say, so what do we do? And the end, he'll say, the patient doesn't look good. Let's operate. He wouldn't have bothered about any of the result and think, the patient doesn't look nice. I think we need to operate. And that is where possibly he was using his AI. It doesn't matter. Sometimes you're not able to explain. People talk about a lot about explainability and interpretability and transparency of AI. Sometimes AI does that. It is able to go beyond what data is fed to it because it is bringing in multiple sources of insight. So there have been challenges about explainability and things like that, but we have to go beyond that. And that's what you will be seeing as some of the examples that I will be bringing in for AI in surgery. I'll just pause here. Any reflections, any questions so far? Are we all on the same page? Vidya, I'm not seeing the chat because I'm in full presentation mode. If there's anything in the chat, just let me know.
Sure. So
Absolutely, we will.
Okay. Professor Bandari, any reflection?
No, I think you are doing fine. Please continue.
Great. Thank you. So when we look at surgery and AI, look, surgery is a very sort of unique position for AI because it is not only bringing the intelligent part of thinking, but it's also bringing movement and mechanical part of the doctor. So as a surgeon, there is a lot of involvement on the brain as well as the hands and our thinking, and so that's a little bit unique compared to say AI in medicine, where it's more related to the thinking part of it. So here it is both thinking and doing, and that's where it becomes quite interesting combination. We've got multiple zones or dimensions in which surgery is impacted by AI. This is just rapidly evolving. This classification is a very one of the ways of classifying, let's say it like that. But AI helps in touch. AI helps in deep analysis. It's able to bring in tissue recognition. It can track instrumentation. It is able to bend and move and lift and bring it into all types of kinematics, as we call it. So in the surgical field, AI can literally do quite a lot of stuff, but it is still not going to replicate the entire surgeon till super AI comes into place. Traditionally, when you look at surgery, we always look at the preoperative, intraoperative, and postoperative sort of way of describing anything. And AI could also come in these various approaches. In the preoperative phase, AI is quite significantly helpful. For us, the main thing that we want in the preoperative phase is, am I taking the right decision? Is the decision good or beneficial for the patient, for the surgeon, and for the system? So AI helps in many ways, including good planning, good decision making, accurate preparation. A lot of complex surgery today, right from transplant to orthopedic surgeries, needs a lot of preparation. And AI has enabled a lot of preoperative preparation for surgery, particularly in the field of simulation, which we'll see. Then in the intraoperative phase. In the intraoperative phase, it's all about being efficient. It's all about being correct in the surgery. It's being doing the minimal damage and trying to do a very efficient operative workflow and keeping complications, intraoperative complications, as minimally as possible, and doing the right surgery for the right type of condition. So there, AI is significantly helping us in many ways, robotics being one, but also in various surgeries, which I will give examples later on, including cancer and other types of surgeries. And in the post-operative phase, AI has got a phenomenal role. In fact, some of the most well-established and outcome-delivered AI examples are in the post-operative phase to avoid post-operative complications, to have smooth recovery, to ensure throughput, and prevent readmissions, prevent recurrence in cancer surgery. That's where AI is got. So if this slide it sort of gives you an overview of where all AI can sort of help. So let me just go into some more specific examples of AI in surgical field, and then I will bring in Professor Bhandari also to give some more discussions about this. In the pre-surgical planning, for example, AI is very useful in very different types of surgeries, particularly in cardiac surgery, neurosurgery, and transplant surgery, where the ability to synthesize or simulate beforehand the whole surgical procedure, to understand the surgical field, to understand the various 3D modeling and complications. It is phenomenally beneficial in using AI-enhanced imaging tools. And this has revolutionized preparation for surgery, particularly in liver transplant, in brain surgery. In many surgeries now, it is being orthopedic surgery. So that is one area. In the intraoperative phase, this is where I think I will hand over to Professor Bhandari after I just introduce how robotic surgery has made a huge difference. Robotic surgery is able to have this interface between the clinician and the patient and the disease, and it has been able to sort of analyze different components, the visual component of it, the dimensions of it, the movement of it, and is able to therefore assist the surgeon in either magnification, in controlling movement, in very sharp dissections, in being able to identify the planes very correctly. There are many, many ways by which how does it do? It has got imaging. It works only by the same senses that we do. Today we have got most of it is coming through distance, through vision, to computer, what we call as signal processing and computer vision. These are two key elements of it. And now we have also got haptic, which is touch and sensation also has come into the place. The only thing we are not using much possibly is smell, but all the other senses has possibly come into place. Professor Bhandari, do you want to give a little bit more about how AI is revolutionizing robotic surgery and intraoperative surgery at this point?
Yes, Shivam, thank you. You made a good foundation for talk. I think in this diverse audience, I would like to make certain remarks, which may be repetition, but re-emphasis on what Shivam has said. I'm making a historical statement. Shivam, you are free to disagree with me. If I see comparing other fields like business intelligence, auto-driven cars, and gaming, if AI is not growing in medicine with that speed, the blame lies squarely with the doctors. Because you are the data mines and AI's heart is data mines. And even otherwise, if all of us preserve our data and understand data science, 90% of our data is unstructured data, which creates another problem. We don't have any example of real-time data. So I think that is number one I want to tell you. And to simplify what Shivam has said, surgeons have always suffered the crisis of predictability in a time sensitive and in a absolutely uncertain circumstances, which Shivam very rightly mentioned in the thing. And everybody is right whether to operate upon a peritonitis or to operate in an acute pancreatitis. But now AI is bringing predictability. That is one of the major excitements. Surgical assistance, it's very important that for two reasons I view surgical assistance is a gold mine we should be looking for in AI. One is the learning curves. In order to, excellence is in pockets, and excellence is merely because of the experience. And when you look at the experience, it is minuscule of the global experience. If 5 billion surgeries are done, somebody is talking of 2,000 cases or 5,000 cases. But still, experience works in our part of the world. So the entire effort of the people working in AI is to see how could we make a learner as proficient and not even proficient, but safe to the patient as an experienced surgeon would be. So that is why Shivam very rightly said, I'll show some of the examples where preoperatively understanding the disease process itself helps. We have 3D models, we have subtractions, we have rotational models, which I'll show sometime. But what I'm trying to say that is what, if you
Shall I stop
understand.
sharing, sir? Do you want to show some screens?
No, I'll just complete this and then I
Sure,
can show
sure.
in a go. So then comes the that when uh, you have the ability. I'm sure young Chinnaswamy will talk about the simulation and virtual reality. But what I'm trying to say that you can simulate all the situations preoperatively by clamping which vessel, what would be there. And latest was few months ago, one of our partners have predicted EGFR of these patients within the range of 90-95% area under curve, that if you do this technique, this is the outcome you should be expecting. So really, we are going same on the oncological point of view. Training is a very integral part, and particularly for India, where it is rightfully free. I am and Shivam are the only privileged people who can criticize the countries we live in at the same time India, because criticism coming from outside is not welcome. But I can tell you, very soon, whatever you do in four walls of operating room is not going to stay within the four walls. And I'll draw your attention to the work of Grantkow at Stanford, where the operating room black box is gaining popularity. Everything they are doing in a positive manner, that a surgeon is disturbed 49 times during 1 hour, and he brings a simile that if you disturb your pilot 49 times, would you expect the same outcome? So operating room black box is definitely, we will have to learn to accept our errors. We'll have to have better methods to avoid errors. So training is something which is very, very important. Two more areas which Shivam has said, but I'm highlighting them, is the speeding the process of diagnosis and treatment. And two examples I'll give, like optic confocal microscopy can give you within 4 hours the final report of the pathology of the patient. Mind you, many of us have patients who have lived, as our relatives lived in anxious moments of taking 2 weeks for the pathology diagnosis to come and all. So that is being taken care of. The AI pathology tools are really performing very well after that. And next thing is accuracy. As surgeons, we have to mellow down our overconfidence that, oh, yes, what I say is right, but AI is definitely more precise, more accurate, whichever area it is, if you really filter out the deficiencies. So I think, Shivam, for the timing, these were my comments.
Sure.
And if Aditan wants to add something, otherwise you go ahead. And at the end, I'll show you some use case examples of what I talked about.
Excellent. So I'll just cover off quite a few of the things that Dr. Bandari spoke in with specific examples for you. A typical good example when it comes intraoperative guidance today is actually in guided surgery, where a combination of the radionuclide plus AI plus tracking of tissues is helping us now in really guiding very sharp dissections, very narrow, very precise dissections. And earlier we had some elements of this without AI, but AI has now made this highly, highly precise. It's actually in millimeters or even sub-millimeter accuracy of dissecting planes has happened. Another good example is real-time monitoring and feedback on the type of surgeries that we're doing. I remember when we used to send for frozen section, we had to wait for about 1 hour. Now with AI and the ability for AI to interpret frozen sections and bring it together and also reconstruct 3D models, it has enabled surgery to be much more precise. That is, it is not visual precision anymore, but it is at a cellular precision and histological precision that it's able to reconstruct, particularly surgical resections and surgical margins, very well. The other example is, as Dr. Bhandari said, is about the predictive analytics. Now, this predictive analytics is something which is very unique, I should say, for AI versus humans. The human predictability is only based on that particular individual's learning curve. And like Dr. Bhandari said, the AI's predictability is by bringing in the entire world's learning into picture. And therefore, the predictability factor, or what we call as the predictability capability of AI, is definitely much more higher. And the only thing is, there can be a lot of, because these are early days, there can be a lot of thing called hallucination within AI. And that hallucination is slowly being taken care of by bringing in the right type of data into the and context. See, there are two things in surgery or in any decision making. One is about the information, but the other one is at the context. It's the same dimension of surgery, or the parameters of surgery will change whether the person is 50 years or 80 years, whether the person is 50 years and a female with from India, or 50 years and from a different country. So the context is another important part. So predictability brings data, insight, and context also together to being able to give that levels of insight. I wanted to do a demo, but I'll do this. What you're seeing is one of the solutions that I have developed. This is one of the solutions where just by using AI, we are able to bring in a lot of prediction of risks for various conditions, and including being able to diagnose, get to know a person's blood test without any device, just your smartphone. So AI is also doing a lot of revolution in cost reduction. We are yet to see all that translated into real life, but eventually it will come there. The other types of examples that I would like to do is, as Dr. Bhandari was talking, in training and skill assessment. Today, particularly laparoscopic surgery, robotic surgery are very amenable for very good skill assessment. We used to say you have to do 60 gallbladders or 80 gallbladders before you're having the ability to operate independently in those days when you're doing open surgery. But today, the learning curve is much faster actually when we are able to bring in a combination of simulated learning with AI-assisted learning, because it's able to immediately give instant feedback for every single action of yours. So if you go and sit back after a surgery, in those days I used to say, sir, did I do well? Oh, you did well. You could have done this one particular part less or thing. Or while doing the operation, they say, no, you shouldn't, treat the tissue well, this is the angle by which you should go. You will get 5 or 6 feedback, or maybe if your teacher is really good, 10 feedbacks for a surgery. That will be too much. Most often we finish surgeries without any feedback, not knowing where we did right or wrong. Whereas with AI, every single movement of yours can be analyzed and it is able to give you a feedback. And that feedback is what helps in further refining your skill, because surgery is both, skill and accuracy, and then comes the brain behind the surgeon. But at least by honing your skill set, you bring in a lot of improvement in the outcome. And AI does a lot to do that. The other big area where AI is becoming very relevant is what we call as personalized surgery. This is particularly key in implants, in 3D printed replacement of organs and tissues, particularly orthopedic surgery, cardiovascular surgery, in valve replacement, in replacement of various blood vessels, reconstructing them through 3D modeling. AI is being very, very good, and this is going into more precise, precision surgery, where you're able to actually do based on each individual patient's parameters. So that's another place where AI, particularly in orthopedics, it's one field where the modeling and ability to reconstruct and precise measurements specific for that knee, specific for that disease is now happening. Then we've got what we call as areas where surgery is able to bring in a lot of training capability and doing it on its own. So one example is AI-driven robotic systems. They are in doing delicate procedures, particularly, for example, retinal surgery, where the movements are in millimeters or sub-millimeter movements are important. We are able to do very delicate manipulations through AI-assisted robotics rather than use our own hand. And we all know, for example, tremors, and AI is now being used to understand the tremors of a surgeon's hand, and then brings in neutralization of movements, kinesthetics, as we call it, by using AI-assisted platforms. There are a lot of other examples within laparoscopic surgery, post-operative surgery. This is another example where how AI is able to recognize devices, recognize the dissection field. It is able to actually guide the surgeon to say that, look, okay, you're in the right field or you're not in the right plane, or whether your plane is correct or not, or whether you have to move a little bit more to the left or right. To that extent, we are able to actually have the guidance, what we call as AI guided surgery happening. And it all happens by the various capabilities, as I said, of AI to sense vision, movement, data, and this is where Dr. Bhandari, what he's saying is right. There are a lot of now databases where people are now collecting visual video databases of errors. And one such platform is called SoCal. By actually having a video composition of multiple errors, say wrong clipping or hemorrhage or wrong dissection planes, it is a learning for the AI to be able to pull that. So the more we contribute to the AI, both on the good and the bad, it helps in finding out ways of assisting us. This is another example of where AI is being used for skill-based video learning, cataract surgeries, particularly retinal surgeries. There is a huge amount of database now where these databases are being used for training and helping them to change their ability to move and skill sets and things like that. And there's a lot of science behind it. Each one of them has undergone a lot of refinement. I don't have the time to go behind it, but at this point in time today, we will just look at an overview, and then maybe we'll have much deep dive into some of these. This is a good example of how AI is helping in predicting, for example, in hemorrhage, surgical hemorrhage. By just looking at 1 minute of the video, nowadays we have got the ability to say, look, this surgery is going in the wrong direction, or it is able to say that, look, this person is likely to have post-operative hemorrhage. Have a much closer look at this person. All of this, you could ask, why, if all of this is there, is it going to make a difference? Has it improved the outcome? We are pretty much in the very early days. These are capabilities that are being analyzed and developed. It'll take a much longer duration because we're just in very last 3, 5, or maybe 10 years. We need multiple long-term studies, which will then establish the outcome, the cost benefits. We are not yet there where AI has become cheaper than humans because of the investments that have gone in. But over a period of time, when such investments are used across a large number of procedures, we will have definite capabilities for cost improvement. The good thing is AI is scalable. AI is replicable. If we had one Professor Ananthakrishnan or one Dr. Bhandari, it possibly takes 30, 40 years before you create another person like that. But with AI, we can create multiple equivalents of, I wouldn't say the equivalents of Dr. Ananthakrishnan, but it's equivalents of whatever that AI can do can be replicated, particularly for rural areas or for places where there is not enough surgeries. Again, I'll pause here. Adit, you want to bring in some perspective of yours before we move into more examples? I hope I'm in the right direction. Am I boring with too many examples?
No, sir, absolutely not. This has been very, very eye-opening as well. I do have a lot of questions, which I'm like maintaining a separate track of. I don't want to.
No, why don't we have a couple of questions if you want, so that we could make it interactive? I don't want to just bore with examples. If you want to figure out one or two questions, let's take one or two questions and collectively answer it. Yeah, go ahead.
Wonderful, sir. So one of the first questions I had was how Professor Bandari also mentioned that we are blame in terms of the data collection systems, and then you also brought that in. So what would be the type of data systems or data collection systems that we would look at, and how realistic is it for us to be able to collect that kind of data in surgical fields where a lot of the moments tracking and even documentation of whatever steps we do, like we do not there's no standardization of that. So what kind of systems or data collection systems would we be looking at to
It's
kind of fine-tune this?
a very, very good question. Very good question. See, we've been very good in collecting numerical data or textual data from our EMR systems and all that. So where having the context is what what is the nature of the patient, what is all the lab and all their various preoperative information, having all the electronic medical record of the patient is very important, because all of that goes into the synthesis of the information. Like, Professor Natarajan always says the key part about a surgery is not the ability to do it. Okay, the mere ability to do a surgery is not its only indication. Some quote, I can't remember who told that, but that was what I was taught to do. Taught thing. So it is not about doing the surgery. He always used to say you can train a monkey to do the surgery. So it's not the question about the surgery itself. It is about the indication, about the decision making. Am I doing the right surgery? Am I doing it on the right person? Am I doing it in the right level? So in order to do that, one is the patient's record and patient's information. The next important thing in surgery is the visual data. So today, as Dr. Bandari said, we got the black boxes. What a black box effectively does is it looks at the entire operation theater, right from the number of times the door was opened to the number of times a sister coughed, or the times the equipment dropped, or the number of times the surgeon had to actually sit down for resting, or how much the anesthetist has been disturbing the surgeon. Imagine if all those parameters came into the picture, and then it is able to actually how many swabs were blood stained, how many times the wash was done in peritonitis. Every single data that is coming through a video is now being able to analyze. So people have now got ability to look at the entire process, including the understanding of the voice recognition. So how many times the surgeon asked for, or his voice was raised, or he was showing apprehension, or how many times he asked the anesthetist, is the patient okay? Is the patient okay? For example, even such data is now going into the training databases to be able to predict. So there is numerical data, textual data, then operative data, then the next thing comes post-operatively. What happens to the patients? What has happened to the outcome? For example, we have the training loop or feedback loop in AI, where we feedback, you told me to resect 2 mm. My pathology now has come back and said 2 mm wasn't enough and there is cell thing. And we feed it back, and the next time the AI learns not to do just 2 mm, but by maybe 2.2 mm. So the databases are immense in when it comes to surgical AI. Any reflection from your side, Professor Bandari?
Professor Nandi, would you like to come in now, sir? You have some comments or questions, sir? You're muted, sir. Kindly unmute yourself.
Yeah, what I'm saying, take control of the time, because three of us can talk forever.
Yeah.
So many things to do. So please take control. And questions are very important. So go ahead with the questions.
Professor Nandi, kindly unmute yourself, sir. You're muted. Sir, you're muted, sir. Professor Nandi, you're muted. Radhakrishna, can you help? Unmute him.
Nandi sir, you're muted.
There,
Yes, sir. Yes, sir. We didn't hear you at all, sir. So please start from the beginning, sir.
I said I'm confessing that I'm a conventional ancient surgeon, but I am very critical of anything new unless it adds value. And I do not always believe that increased accuracy improves outcome. And I would like to know, say like you do an appendectomy, would that, using AI, would that improve the result or not improve the result? And I do not believe in statistical significance. I believe in overall actual differences. And before one introduces very expensive technology like AI into developing country like India, where everyone will want to use it, you just escalate medical costs and without improving outcome. Is there any sort of randomized prospective study comparing the use of AI, say, in liver transplant or in gastrectomies against not the use of AI? And what is the difference? And what is the difference in costs?
Very, very, very valid and pertinent question, sir. I'll just take I'll try to answer it, and then I'll also get help from
Shivam,
Dr.
if you
Bhandari.
could just stop sharing the screen temporarily and also tilt your camera so that we can see your full face.
And I'd like to say hello to Dr. Bhandari, who I've known for about 50 years or more.
Yes, you are
Dr.
right,
Bhandari.
But your questions have
Remember
not
me?
changed at all. Yes, I remember. But your questions and your way of thinking is infectious. So it would be fun to interact with you on these areas you mentioned, very vital. So would you have a crack, Samiran?
Yeah.
No, sorry, Shivam.
Yeah,
Here two
see,
questions. One is a value add and activities, and two, precision is not required. Is it cost effective for every situation? We gave example of gallbladder.
yes. I think I will talk about the outcome first. So the outcome science has changed a lot, Professor, and it has moved, as you said. In it's not anymore just accuracy. When we talk of outcome in surgery, it is not just outcome for that individual; it's also outcome for the system today. So we have to keep in mind when we talk of outcomes, is it first of all we're talking for that patient, outcome for the consultant and the surgeon, has it worked well for them, outcome for that whole department, has my list moved appropriately, have I wasted time, or have been able to bring in adequate flow of surgery? So outcome is a very big area to talk about. And to be honest, because of the lack of long-term studies, we have not yet got that level of depth of information to be able to say, yes, AI definitely changes outcomes. But there have been focus studies where definitely, particularly in the region of in urologic surgery, because that's where a lot of robotic surgery has been started and used. There's quite a lot of outcome studies, particularly in prostatic cancer, which possibly Dr. Bhandari will answer, where there is now studies coming up with improvement in outcomes in terms of survival. Whether there is a randomized control trials and the number of randomized control trial, the evidence level is still, I would say, not yet built to be able to be confident enough to say that it is there. In terms of value add and in terms of the economics of AI in surgery, definitely at this point in time, again, it is a very cost intensive affair when it comes to various types of infrastructure that has been needed, as well as the development of all this, which is, but over a period of time, once we scale this up, the ability of AI is that it can be scaled up rapidly. And that is where we will possibly soon see some value. A good example is diabetic retinopathy screening. When investment was being made into it, it was about 200, 300 million pounds when Google DeepMind put its investment. Now, we are able to do diabetic retinopathy screening in a simple pharmacy lab and in a simple pharmacy without even an ophthalmologist, and it is 99.95% accurate for diabetic retinopathy. Now, that has been now multiplied and it has now reached over a 1 billion population to do diabetic retinopathy. So what was just a 3 million pound investment is now able to do screening without an ophthalmologist. I'm just giving that as an example to say that over a period of time, there is likelihood of getting this benefit. But to be honest, I cannot tell at this point in time whether we have enough studies to substantiate that. That's what I would say. I don't want to be an arrogant AI surgeon, but I want to be humble enough to say that, yes, we don't have enough answers for that.
See, I'm worried about what
Yes.
Dr. Arnold Relman, who is editor of the New England Journal of Medicine, said about medical industrial complex and
Yes.
how industry is taking over medicine. And AI is one of the industry's foremost champions. And I'd very much like to know. I think that outcomes, you should look at mortality, morbidity. I think that other things are not so important.
Mortality and morbidity in very specific types of surgery, it's already been proved, sir, and definitely there are many papers which are coming now, particularly in the ability for it to predict and prevent post-operative complications. There are enough studies, and I can send some examples. I've got 1 or 2 examples of them in this own slide deck, and definitely there is there. But it is only in selective fields. It is only in specific surgeries, but it has not become a generalized statement to say that it is going to improve in all surgeries. Because the ability for it to improve mortality, morbidity outcome is based upon the number of, it's like our own surgery training, the number of times it has been used and trained till it becomes really good enough. So, and the good thing is it is constantly evolving. It's not static. So that's the good news. We have seen the evolution of AI within this last 5 years dramatically improving. So that's the good news for us, or the positivity behind it. It's not a single static level of training or competency. Adit, you want to add anything, or Professor Bhandari, you want to answer anything? I think he's had some other thing. Anyone else? Professor Antakrishnan, you want to come in to sort of either debate it on either sides? Professor Bhandari?
Yes, I think I would make some general comments to Samiran's question. They're very pertinent questions. Let's take overall AI. Is AI making money for anybody? No. Not even Google, or no, not even OpenAI. So, but the investments are huge. So basically the money generation is either by service providers or it is by the research money which people do from NIH or other branches. 2, value add is definitely a question which is not only for AI, for everything. Because we do so many things, but ultimately you have to see the overall value add to it, so that it's not contested. Samiran's question about evidence where it has been proved superior to, Shivam can add, or Nitin can add, but I can think of only one area, which is the radiology or imaging, where sufficient FDA tools are there, and they are in practice, where more than 16 radiologists, one study I'm quoting, board certified radiologists in speed and accuracy, both AI was better in that. So such evidence you give retinopathy and things like that. One question I want to answer, Samiran, what he raised, that is it cost effective to be precise in every surgery? Yes, I agree, not necessary. But gallbladder's example is one extreme example where you can do away without it. And that's why even robotic surgery is overkill for a gallbladder, that gallbladder simple nephrectomy. However, it becomes immensely important for nerve sparing and radical prostatectomy. And there are models which have shown improved results, and there is a work in that direction. So every surgery, every AI tool, and number one, I have a problem with the word artificial intelligence. I don't see anything artificial in it. It is augmented intelligence. It raises surgeon's cognition. AI is a butter slice in between. All AI begins with even writing algorithms by the human beings. And before human use, they have to be validated by human beings. I don't expect that anytime we will be able to apply AI directly to the patients.
Yeah, I'm not criticizing AI in general. I'm just saying that you cannot apply AI for everything. I think that there must be a place for it where a normal or conventional treatment is or investigation is not working, and where it is cost effective, especially in a poor country.
Absolutely.
I think a lot of this is by private hospitals trying to attract customers, which I've been against for a long time.
Ajay, you have your hand up. You wanted to say something? Ajay Sharma.
Thank you very much, sir. Thank you very much, madam, for asking me to contribute, Vidya. I really enjoyed listening to Dr. Shivam when he says that the end of the bad test really is much more informative and has got overwhelming influence on decision making than some of these investigations or the numbers. So I'm just quoting what Professor Bhandari had asked us to do the analysis and writing that paper on how AI and machine learning really is helpful. And based on the data of 42,000 patients, 72 million events, which were analyzed retrospectively using AI, it showed that it is possible to predict the mortality much better in acute care setting. So again, I'm somebody, I must say that I'm a technophobe. I really use technology only when it is really necessary. But it just goes on to show that probably AI or machine learning reads much more than our eyes can see or my mind can really interpret. So that's the reason I thought when somebody asked what is the evidence in favor of it, so we have got this level 2 evidence. So probably Professor Bhandari asked me to be involved with this because of interest in evidence-based medicine, skill development, and perioperative care courses which I have been doing. So I thought it is worth highlighting a paper of Professor Bhandari himself that he inspired the team to write. And I've quoted it in the chat box. Thank you, Vidya, for asking me to contribute.
Thank you. We have
Vidya, with
Dr.
due respect,
Makam
Vidya,
Ramesh. 1 minute. We have Dr.
I
Makam
have a
Ramesh.
word. See, with due respect to my mentor, Dr. Nandi, Dr. Nandi raised the same question 30 years ago about laparoscopic surgery. He was very much against, and but much water has flown under the bridge.
We have Dr. Makam Ramesh on the call. Did you want to say something? You're muted, sir. Kindly unmute yourself.
Thanks for this opportunity. What I just had a critical comment on the slide that was shown and what we were talking about laparoscopic cholecystectomy and callus triangle. Callus triangle is just a visual impression of the whole anatomy. But then I think there's so much more. When I'm operating, I look at the induration of tissues. When I have a nice callus triangle, I don't need any artificial intelligence to tell me how to go about. It's only when I don't see a callus triangle that where I need guidance. And that is the time I need something else. I need ICG, I need a Doppler, I need a intraoperative ultrasound to guide me. That is what my feeling is. It's computer vision may not be an answer for image guided surgery in all instances. That is what I felt. I would like more discussion about it.
Makam, you're right. What I gave there as an example was just to show where computer vision has come into play. AI is now taking different types of data, different types of inputs into it. So we are in that process of evolution. I'm not saying that it has come to its end and it's come to its thing. So today it has taken computer vision. It is even taking into picture the ultrasound and echo data. And we will have probes. Today, we have got probes which are only looking at touch or tremors. Soon, you will have probes which are going to look at temperature or going to look at even the pressure and to look at even the texture. So already those probes have also come into play. Whether these are good or definitely going to make a difference is definitely a question like all of us have. Is there a worth in looking at specific use cases and specific examples where it is going to be beneficial? That is where we have to focus our attention and see that in the short term, when I say short term in AI, it can be anywhere between 1 year or 20 years. What are the various specific indications for which this is going to make a huge difference? And that's where the industry is going and focusing on.
I think that's very important. Where is AI going to make a difference? And
Absolutely.
where is it over conventional diagnosis and treatment? People have
Absolutely.
said that, especially for the third world. For the third world. I'm very interested in the third,
Sir,
and North America.
Yeah, I very much look at what Dr. Nandi is telling. He's a father figure. He has seen what's happened over the last 50 years. Today, I can tell you one example. We have robots in most of the hospitals, corporate hospitals. An ex-student of mine joined the one corporate hospital where I'm practicing, and he started doing cholecystectomies and appendicectomy using robot. And then he is the hero of the hospital. Now, is that the right thing to happen to India? Is what Dr. Nandi is asking. I mean, is there somebody who has to be overlooking such things happening? Is what we should answer.
I think we have multi-dimensional discussion here, right? There is one, the science behind it; two, the economics behind it; three, the politics behind it, right? And you cannot merge all of that into one talk and be able to justify it. There is definitely worth in looking at how you take these things and bring it out to a system. The way I introduce AI in possibly or AI-based surgery in UK or US might not be the right way to introduce AI in India. Will definitely not be so. And even in India, whether it is introducing it in Chennai is going to be much different from introducing it in Tindivanam or in Chengalpat. So I think those are further progress that we will be making as these things. First, you need the ability to do the surgery. The invention has to happen, and then how the invention permeates into the society is a different issue. If Edison has stopped inventing that bulb and said that, oh, bulb is something very difficult, today we all wouldn't be. But so it takes that time for that invention to then permeate into society and to bring in societal value. So I think we shouldn't complicate too many values here. There is a surgical value, there is a patient value, there is a societal value, there's an economics value. And if you want to bring everything together in the first 5 years of something which is so complex being invented, it is unfair on us also. So I think we have to have that patience. And yes, it is right to question whether that cost in that area of invention is right or wrong. And as Patta said, possibly time will tell us. I don't want to make this, I wanted to actually go more into the scientific side of this discussion, but definitely it is worth also discussing the pros and cons and the benefits. And for example, I'm actually doing a whole research now and having a special interest group into the ethics of AI. So no one, unfortunately, no one even opened that question. So, and that's a very big minefield by itself, where the various ethical dimensions of AI and its implications, which is mind-boggling. The other big area I thought Professor Nandi or Professor Antakrishnan would have raised is the regulatory environment in which we are doing all this. The old world regulatory environment, the old world ethics by which we were operating doesn't apply anymore to this new world of AI and data-driven surgery and medical care. It is a big night. It's a minefield there from terms of ethics, and that's again another big area to look at.
Ravi, you had your hand up. Did you want to say something?
No, actually, Shivam just answered it in the last few seconds of what he just said, which was basically I wanted to look at the the regulatory framework for all of these, because the flip side of using AI, not just in surgery but in any other situation, is to use it in research. And in order for it to be applicable, say, use AI-based algorithms for pathology, you require approval. The scanners have to be approved. The AI algorithm has to be approved. So there's a whole set of steps that need to be followed. What are those for clinical practice, for adopting this in clinical practice? I mean, you just can't say this is new. Hey, we're going to adopt it, right? So what are the regulatory framework, as well as, and obviously it'll also go to Dr. Ramesh's question, the oversight.
I have an entire presentation of regulation in AI, which will take another 1 hour. But in summary, what I want to say is the regulatory framework had always been what I would say top-down regulatory framework in the past. What AI and technology has done is made it bottom up. Okay, because when I say top-down, what has happened is it was always against the ability to innovate. I wouldn't say innovation is always good, but what happened was regulation was always top down, and government and regulatory bodies putting their pressure on how innovation could happen. What has happened with the new world is it has become pro innovation, and therefore it has become more bottom up. What do patients need? What do customers need? What do end outcome the citizens need? And that is driving the regulatory environment, and regulation has become pro innovation. There are so many aspects of the regulatory framework, because there is the regulatory framework covers not just the patient, it covers the vendor, the industry, it also covers the user, the doctors and the healthcare professionals, and overall the health system itself. And there are many innovations that have happened in the last 10 years in the regulatory space. It's a huge topic, and happy to possibly take that as another possibly discussion, regulatory environment in AI and data. That's huge.
So we'd like Dr. Piyush Sani to come in. Meanwhile, Pankaj has a question. Is it far enough developed for the medical curriculum to be tweaked?
Sorry, for the medical curriculum to be? Tweak. Well, definitely. I know there's already a lot of tweaking happening in the medical curriculum when you're talking of IT and data and the role of bringing in computerization in medical education. So there is no doubt that we have to now get our youngsters and our new generation of doctors becoming proficient in this. There is no doubt about it, and we have to make them cognizant of it. They have to be educated about it, and you can't just avoid it. How much and how, it all comes at a cost. Do I stop teaching enough of anatomy and then bring this, or do I make this course from 4.5 to 6.5 years course? So those are things that we will have to struggle with, and I think educationists like AK, Professor and others would have to find answers for that.
Shivam,
I think,
if I might just interrupt, what I'm saying is, do we need to have it as one of the subjects?
That's what
just
I'm
the other
saying.
day, I was reading that China has introduced AI in primary school. Are we so far behind in that case? That's what I'm asking.
I'm saying there is a definite role for bringing in. How much of it has to be brought in, at what stage in the education it has to come in, and what will it replace? It's all opportunity cost. If you bring in AI into it, do I teach anatomy, physiology, surgery, pharmacology? How do I do it? So this is going to be a new area or innovation and revolution in that. Professor Anandakrishnan has raised his hand, Vidya.
Yeah. I was just waiting for you to finish. Yes, AK sir. Dr. Piyush is also ready after that.
So you're muted,
sir. Unmute yourself, sir. AK sir, please unmute.
Can you hear me now?
Yes, sir.
Well, Subbu, nice to see you. We go back a long way, and it's always nice to hear you talk. But, I have been influenced a lot in my formative years by Dr. Samir Nandi, who joined the All India Institute when I was there. He was one of my early role models, and my way of thinking is similar to that, seeing what is actually happening. I'll start by saying in an ideal world, things will go stepwise. And depending on utility and the benefit that we get, things will get employed in the clinical medicine. But you know, and I know that medicine is not nowadays what we should see in an ideal world. Often the procedures are dictated not so much by the benefits that they bring, but by the income which they generate. So, and as you yourself said, it may take another 20 years for things to become stable and the benefits to be apparent to all, so that the additional investment or the additional cost can be justified in each and every case. But I think that caution we did not see. We saw a lot of caution when minimally invasive surgery came. It did not proceed to all the organs, it went in a stepwise way. But when robotics came, it didn't happen that way. Without considering the benefits, whether they justify the additional 2 or 3 lakhs which it cost to the patient, it started getting employed in every situation where the benefit, if at all, was marginal. So what I am now concerned is, and I'm really concerned because, you know, we have worked in Jipmer where it was all poor patients who used to sleep on the roadside throughout the night in order to come to us. It was so when I was in All India Institute. In the corporate world, it's different. For at the current phase, I feel pattern recognition, pathology, imaging, reporting of imaging, or even dermatology, it may be justified to use it in every patient. But when we start propagating it as if it's the next thing to heaven, then there is an issue at the stage at which we are in now. Maybe 10 years, 15 years, the cost will come down and the applications will be clearer, the benefits will be clearer. But we as clinicians always have to weigh. You see, even now, getting an advantage in diagnosis is certainly beneficial by using AI. In predicting prognosis, it's certainly beneficial by using AI. And as you yourself mentioned, to image the retina in diabetics, which is such a common problem, it is very much useful because you can prevent some blindness by taking appropriate measures when you diagnose and microaneurysms and all these things. But human beings, they neither have NI or AI, particularly when we get involved in medical treatment. So therefore, caution has to be exercised by in propagating it as a solution for each and every problem. That is my concern. It's not happening, but I'm afraid, having seen robotics, I'm afraid it will happen. That's all I have, but otherwise, your talk as usual, this thing, you and I go back to your undergraduate days, so I've heard you a lot. As always, it's very interesting. Thank you so much.
Thank you, sir. Thank you.
Professor Piyush, if you'd like to come in. Meanwhile, what you all have been talking has been put on the chat box by dermatologist Not Anand. That in dermatology, we have many AI apps to analyze dermoscopic findings of suspected melanoma, lentiginous nevi. Though we do not know the sensitivity, there is a case for use of AI dermoscopy for selecting site of biopsy in such pigmented lesions. So that's a clarification. Yeah. So, Professor Piyush?
Thanks, Dr. Vidya. I'm no great expert on AI, and I have my own sort of, way of thinking of where AI is taking us. I think AI is going to keep generating more and more ideas for us to battle with. But the question that I have relates to a statement that I heard at a meeting where somebody was talking about AI in surgical gastroenterology. And he suggested that the data that is being fed into the AI systems are largely male dominated. And very little data which is related to women is getting into the AI systems. And that's because the people who are working on AI are mainly males. So is that a cause for concern? Is that a worry? Or is this true?
Yeah, there are many ways in which bias enters into AI, and there is many reasons why that enters, and that has been one of the big sort of what we'll say the drawbacks in AI algorithms, and that has been identified, and people are understanding that, and one of the whole regulatory framework now is around explainability and transparency in AI. So in the last sort of 3 to 4 years, not even three, in the last 2 years, the AI regulations have now brought in various dimensions under which AI is being regulated. And one of that is called transparency, the other one is called explainability, the other one is around bias, and another one is called hallucination. So there are many dimensions in which AI itself is now being scrutinized and looked at, and are trying to avoid those errors. So that's a very important point. And the developers of all these solutions are also not only aware of it, now they are going to be held accountable for that, and therefore that part of it is being corrected. But I just wanted to reflect on what Professor Ananthakrishnan said, Vidya, is that's a very important point for us to understand, that it cannot be universalized. We are not going to make AI as a universal solution for all surgeries, but definitely it has got values in specific example. That's for sure. But one thing, sir, is that there are pioneers in each areas and in each surgery. For example, even liver resection or even doing liver resection was not so important about 30 years back, but the more and more we became skilled, now we are trying to do more cancer surgeries and liver resections and liver transplant. And all that was promoted and pioneered with caution. And that's a very important word that you brought in, sir. And I really value that word. That how do you bring in caution into a field? You bring in caution into a field by three sort of areas. One is self-regulation, and that is what is more important. That self-regulation is very key for us as surgeons, as academicians, as professionals, to bring in self-regulation. We don't do something just because I want to get that, like one of our colleagues said, to get popular in that city, to say, put a AI surgeon. No, if that is the way we are being incentivized in our life, that is a very wrong thing. So I think self-regulation, it starts with self-regulation. The next important thing is the external regulatory environment. That by itself becomes the next level of how we look at it. The third thing is good or bad, market forces ultimately drive it. Whether it be a poor country or a rich country, I've been doing a lot of work now in health economics, and I can tell you that whatever we try and talk in terms of societal value or ethics and all that, finally there is this invisible force called economics that drives everything, and that we have to be cognizant of. And that economic force is equivalent to a spiritual force, literally. And that's how people are now equating it. And therefore, we have to respect it. Ultimately, we are living in an economy, and that economic force by itself will determine how these things evolve. So I think we need to have caution, but we'll also have to go by various drivers of such changes.
So Shivam, at least in India, right now, more and more women are taking up surgery. In fact, postgraduates in surgery, there are more women than men. So if what Dr. Piyush is saying, that the data is that being fed is predominantly male-dominated, the results of it may not be applicable after 5 years. That's just partly.
We may have to have a reverse complaint.
So we have Dr. Prashant, who has made some very valid comments. So Dr. Prashant, would you like to come in now?
Yeah, sure. Can you hear me?
Yes.
Thank you, Professor Vidya, for allowing me to speak. Basically, I tend to agree with Shivam regarding different approaches we need to follow when it comes to evaluating AI generated tools or surgical techniques. But based on my personal experience, we recently got a research project approved and working on it. We almost completed it, and it's worth close to 50 lakh rupees in Indian rupees. Current time in Oman. I just pick up my trades. So I think personally, AI is still very expensive, and at this point in time, I think we need to be very cautious because we know industry is pushing this technology through social media, marketing, and all. Somewhere, we as physicians are not experts in this field, and we should not be, misled or misinformed by agencies or the industries in this regard. And we need to look at the fitness very seriously, especially in countries like India. So that word of caution should be kept in mind, and of course there is need of collaboration between physicians and technicians, in this case programmers and data engineers. And so this is all I wanted to say.
Yeah. So, Shivam, Ajay had also mentioned the same thing, that about self-regulation, co-regulation, and then it should come from outside. So, Dr. Prashant, you also had some comment about the revenue generation from AI in the beginning, if I'm not mistaken. Did you want to say about that as well?
Yeah, sure. Basically, these companies, they are not transparent, to be frank, and we don't expect them to be transparent as well, right? So, as per the doctor stock markets, and definitely there's a lot of profit being generated, and of course they are into business and they are entitled to do it. But somewhere we can compare this with the vaccine lobby. Sometimes we is pushing vaccines. So similarly, there is a tendency to exploit people's aspirations somewhere in this regard. So definitely, I think these companies are profitable.
I think there is a very important point to be brought in here, Vidya, is about what is this whole element of how industry is involved in AI. See, one of the things that happened in the past is because it was man-to-man training, it was human-dependent training or human-dependent research, we couldn't scale it up to this level. The rate at which information, data, insights has been pulled in data-driven, AI-driven fields is phenomenal. It's phenomenal, and it has happened at such a huge rate that it's almost like the logarithmic curve. So we cannot compare the traditional ways in which a particular branch of medicine or surgery learned. It took 15, 20, 30 years before possibly cholecystectomy became a laparoscopic cholecystectomy. Then it became maybe 10, 15 years when lap chole became much more prominent. And then it is now in 5 years in which robotic surgery is taking over. The reason for this ability to learn and self-learn rapidly, that itself is a very big incentive in the knowledge industry. When you look at it in terms of knowledge curve and acquisition of knowledge, data-driven, AI-driven, technology-driven world rapidly increases, and it is transparent also. It is not hidden. There could be enough number of fudging that we could have done in our research using our MRD, but it is not anymore that. It is much more transparent and it's much more accountable also. Ultimately the man behind all of this drives it. So it is the human forces which will drive it towards the right direction.
Shivam and Vidya, I will have to leave for another meeting. So I just like to thank you and give a brief response to all the questions, my comments, so that I'm permitted to leave. All the questions raised are not new to us. They are linked with new technology. And we are talking of two things: development of technology. All these questions, according to me, does not make you immune not to keep a pace with the development. Then only you can make informed decisions. Where should you use it? Anand talked about robotics, and I am fully aware of the scenario of robotics in India. And this was very conscious happening. It happened in lithotripsy, it happened in robotics, and it will happen with AI also. But I'll give one example you don't ignore. Kidney tumor with IVC thrombus. At least in my career, I would have done or supervised 100 cases. and 10% mortality on table, 20 to 100 units of blood transfusion, and 7 days elective ventilation if he comes out. Now the whole scenario has changed. It is like lesser than a sebaceous cyst removal, and by evening the patient is willing to go. You can't ignore. So what we are talking of misuse of technology, industrial nexus, they are very much, we are used to all that and we'll have to grapple with. But my only plea is that don't throw away the technology because of the negative point. Try to be with my sincere purpose of being with technology so that I am part of this excitement and learn from it. Where I use it depends on my totally personal ethical standards. So thank you very much. Thank you, Shivam. Thank you,
Thank you. Thanks a lot, sir.
Radha. And I enjoyed, and I'm sorry I'll have to leave. So.
Thank you so much for sparing your time the first thing in the morning, sir. Pankaj, you have raised your hand. Did you want to say something?
Before Dr. Mahendra
No,
goes,
I think Dr. Bandari just answered that, because industry, we are already dealing with the industrial influence and all that, and that is going to be a natural thing which is we have to deal with even in AI. But having said that, we cannot deprive people, the human, the mankind of AI by our personal fears about getting replaced. That's the bottom line, I think.
Sir, you were trying to say something there. AK, sir?
Who said that?
AK, sir, you wanted to say something?
Yeah. The only thing is that I agree with Mahendra when he said we should not stand in the way of progress. But the example he gave us exactly what I'm saying, that we have to use it in appropriate situations. That's all. That situation, none of us here in this forum today will say that AI is not better. But human beings are what they are. That is the fear we all have.
So, Adit, you've been awfully quiet for a long time. We'd like you to come in up with after all this barrage of questions and answers. And if you don't mind, please turn your camera on.
Yes, absolutely.
Yeah.
I think it was a very interesting discussion, and it actually got pulled a lot of ways. I was, and I'm sure Shivam sir also had like a deck prepared to go towards the scientific aspect of how.
No worries. I will share that on the group, and there are another 30, 40 slides, and it will be useful for them. This is more important that we debate thing. Go ahead, Adit. Yeah.
The ethical use of AI has been debated for a long time. Like Professor Bandari said, it's been thrown, and we've gone through that cycle all through, and I'm sure that's going to continue being there. But that discussion and that effort, like I said, like it was correctly pointed out, shouldn't maybe slow down the research, shouldn't slow down the funding. And there was one point about how AI is not is already profitable, but the valuations are again like a smoke screen. That those valuations are based more on potential of where it could be rather than something which we're seeing on ground now. And it is something which you can and should be betting on at this point of time is probably what I would say. And the challenges of what we are going to see in terms of actually developing AI in the surgical field will need so much of support, so much of buy-in. And I think that's where probably you also correctly point out that it's very important to have these discussions to make sure everyone's on board to actually fuel the development and prospective areas. So that I think probably we can continue with your presentation if possible. I would love to see the end. If we're not going to do that, then we can probably shift gears and only go into like maybe one particular area of focus for debate or on for the remainder of the time. If you want to debate about AI's ethics, then that might be a place to stop.
So, Adit, I have a slightly different suggestion that Shivam decided to pause at a particular point, and we were kind of 30 to 40 minutes into the presentation. So, I think we will do part two. For the rest of it, we'll do in another time rather than trying to squeeze it now. So, rather than just sharing the deck, whatever was the content that you had planned, Shivam, for, we'll do it as a part two maybe next month or something. We'll work out a time and date which suits you. Meanwhile, Nalla has his hand up. So, Nalla, go ahead.
Nalla, you are muted.
Sorry, thanks, sir. Shivam is my younger brother. Now, the number of slides he put and the number of details he has given is because he's not a practicing surgeon. He spent all his 20 years only working on AI and tech. So
Hey.
for us,
Hey.
no, I'm just adding. It's
What
true.
we lack,
Yeah, just what I'm
what we
saying is,
lack here
it's very
is
difficult. It's
Kaveri to
very
add to
difficult.
the debate.
It's very difficult. I know Dr. AK has trained you and everything has been fine, but it's very difficult for a busy practicing surgeon to get involved into all this. Like Pata will say, come on, leave it, and he'll go and
They'll
just
make
paint it.
orange juice and give you Nalla. They're not expecting a busy surgeon to pluck oranges. They are just telling,
So,
wait for us, we'll make orange juice and give it to you, and then you decide whether you like the flavor and decide whether you want to have it in morning, afternoon, or night. Like, you know,
and the other thing I wanted to
without ethanol, right? So,
but the other thing I wanted to share with you was, like everybody was talking of the third world. Come on, India is progressing in a big way, and India is talking only about AI, and they're going to. Pankaj is asking, do you have AI in China schools? India wants to make maximum number of AI graduating people, trained people, and AI is being used in all the industries. So why healthcare industry we are not able to? That's because we have busy people working. So we need more manpower, like Subbu, to come and sit there and get things going, and that will be fine. And the last question is, I don't know how much of AI in clinical anesthesia you or me can practice apart from data collection and all that. In clinical anesthesia, maybe the black box can see us sleeping behind the curtain. But otherwise, how does AI help a clinical anesthetist who has a critical time to act?
Vidya, can I answer Nalla in one line?
yes, sir.
Can I?
Yes, sir.
Yeah.
Yes, sir.
Nalla, in industry, if AI adds to the cost, they will not proceed with that. Whereas in medicine, they will do that because that cost will be welcome. That is the issue. That's why we all insist on appropriate use.
It's really true. It's very true. In terms of how anesthesia, in fact, anesthesia is one of the maximum data generator within an operation room. And the good thing is most of the data you generate now is electronic. And therefore, what they are now doing is actually correlating the monitors and the responses. In fact, they're able to predict hemorrhage in the operative field by the various parameters that's going on within you. After all, what do you guys do as anesthetists? You look at those monitors and then come to your insight and conclusion. And AI is now being able to do that. So in fact, the anesthetist equipment and anesthetist side of the data is one of the biggest data feed into AI in surgery.
Prediction of hypertension is quite validated now. I mean, there are enough studies to say that, you know, the predictive
and post-operative complication risk and post-operative ventilation need, post-operative pneumonia. These are all well established predictive models. And therefore, you can prevent them and take appropriate action to avoid post-operative complications.
Yeah. So, Ajay, you had turned your camera on. Were you trying to say something?
No, I already made comments. Thank you very much.
So I think we have, I don't know, there is a question towards the end which I did not understand well, but it's about somebody not understanding. So if you can address that from Jasmine, sir, what is not AI? I'm often confused with the present software that are available and find it difficult to fit the term AI. So could you please clarify? So we are kind of, maybe she joined in late, I don't know, but...
So we'll have to go back to the presentation first slide again. Effectively, the ability for machine to be able to take a decision or simulate a decision based on the data available to it. And the machine taking the data and using it for a decision or an insight. That's what AI is. Maybe when the next talk comes, we'll start with the first slide, but I'll not go to the rest.
So is it going to help democratize surgery? Like you said, no, there was
there is a role for, I mean, it's all far ahead, you know, because see, the AI in surgery needs to reach almost general AI and super AI status to do all that. That is, when you say democratization of surgery, what it means. You have got a robotic which is
What I'm saying is
self-operating.
there are few people who are very good at it, but there are millions of people who need to be treated. Is it going to be help lift the average surgeon into the more safer category so that democratization as in user, I mean, as in
Okay.
the receiver of care or the
Yeah,
patient?
for example, in training, as we said, in training and simulation, our own Dr. Dinakar Pai is now running the simulation labs, and where there is so much deficiency of training material, AI is definitely going to help and the simulated trainings are almost realistic training, and therefore, particularly in training, it is doing a marvelous job in giving feedback and improving the efficacy of surgeons and reducing their complications. So definitely, it's an incremental growth, but definitely it does help.
Yeah,
And
we are all.
I'd like to add to that as well. So I think one of the things which a lot of people generally assume with AI is that it's going to do something which the leading surgeons today or like a majority of the surgeons today can't do. I think that will be the last barrier for AI to breach. But what it will do is actually push the lower end of the bar much higher, meaning again, it will guarantee minimum competencies. It can help surgeons cut basic errors. So I think that kind of assistive AI is the first thing we'll see. And that will probably reach the broadest spectrum and have the biggest effect. So I think that is probably maybe where we can see AI get democratized surgery in a most efficient manner.
Exactly. That's what I was trying to ask. So we are almost, I mean, we are actually out of time. So Radhakrishna, would you like to come in? I'll just look at the chat box meanwhile if any question is left unanswered.
I think it's a very wonderful discussion because when I see the gods of surgery, Dr. Nandi and Dr. Krishna, Nandi is sort of very skeptical about it in that his own way. And Dr. Krishna is questioning the ethicality. I think that balance is very much required. This has to be because it's very sad. I totally agree with Dr. Krishna. The way robotic surgery is going in the corporate sector, it's terrible. And also, Dr. Markham saying that the chap who does the robotic cholecystectomy and hernia surgery is the hero of the. I mean, that is what is happening. It's very, very unfortunate. But having said that, Dr. AK's contemporary, Dr. Mahendra Bhandari, is going the other direction, and I think we need to have a balance in that manner. That is, and of course, Shivam is somewhere in between, and he doesn't want to ruffle feathers. But I think it's an exciting area in surgery, AI, and it's becoming exciting more and more day by day. Actually, I think the day will not be far off when a CT scanner. If you put a patient with a colonic malignancy, it will not only diagnose histopathologically, it will say that it will dictate a robo where to put ports or how to cut and stuff, and then it will also eventually suggest a chemotherapy robo saying which chemotherapy to give, when to give. And I think this is all going to happen. I don't know whether, I mean, many of us will be alive to see that, but this is the way forward. Very, very interesting. And it's always lovely listening to you, Shivam.
Thank you.
There is one comment that we missed, Shivam. Randomized control trials might be very difficult in this setting as the intervention changes too quickly, thus altering the standard of care. So because, as you mentioned, AI keeps getting better every day. So when we started the trial, the level at which it was may be different from the time we end the trial.
Vidya, research is also changing every day. Look, the way I did research with the Prof. Chief 35 years back is completely different from today. If you look at the way COVID has revolutionized research methodology, it's amazing. So we have got a whole world of a field called real world research or real world data. And real world data doesn't have to depend on purely having one randomized control trial running for 20 years. Real world data and the analysis of real world data has changed research methodology significantly. I think, see, like, the day when Professor Andakrishnan taught me to do a simple research starting, I think the first one was, sir, it was,
probably.
yeah, it was on using cotton versus silk I think and I think that was my first paper or something. That was sitting in our MRD and going through 100 records, of which 22 only I could find, and therefore I don't know what bias I introduced into the remaining 88 I couldn't find. The statistical techniques have changed. So I think to answer that question, you don't always need to rely on that old world gold standard. Still, it is still the gold standard. I'm not denying it. But I'm saying there are new research methodologies which have evolved with the evolution of science, and we have to learn to adopt that. And that's significantly becoming very rapidly adopted now.
So, Puneet, we missed hearing from you. So if you want to say something quickly, we can. Yeah.
No, I think fantastic. It's been a, I think it is a frontier, and as everybody said, I think it needs to be tempered. We need, the excitement of that, like the robotic. It has to be tempered with realistic things. What I really wish is that we are truthful about everything, because as robotic and lab came up, I see a lot of hidden. Nobody's going to declare how many lap incisional hernias have died under them. I have seen patients, and I don't think that anybody's going to report them, but we just put it under the carpets. We are aware of bile duct injuries being more. So I think if we are honest, I think that improves the AI. I think the day is not far when AI development, the AI is going to predict based on the previous data which drugs are going to cause what kind of toxicity. So they can probably, from a battery, what they used to in R&D used to choose from so many try each of them on animal. We fast track that. So I think we're going to read the AI continuously. We just need to temper it, neither with custom nor with completes. It's there to stay. We need to temper it very, very appropriately. Thank you.
Your closing comments, Adit?
I'm waiting for round 2. I think a focus session on maybe one particular aspect where we can deep dive into some of the clinical and scientific challenges that we are facing in developing AI for surgery. I know that we touched upon radiology, physiology, but some of the minutiae where we are looking at AI impacting surgery, right from the mechanical aspects of the robotics and the tremor stabilization, that would be fascinating for us to deep dive into some of the science behind that. So if we can have the follow-up session whenever time permits for Shivam sir and the rest, I would love to go further down that road and explore some of that. And overall, I think a brilliant session in terms of understanding what the concerns are with most of the leading surgeons and like senior members of the fraternity towards AI as technology generally is. It was very eye-opening, and the discussion was very, very enriching.
Your closing comment, Shivam.
Vidya, thanks. I just want to go back 35, 36 years. I got both into medicine and surgery, and I took surgery. And then Professor Chandrasekhar was a bit upset, and he said, join பண்ணலையா மெடிசன் என்னப்பா நாங்கெல்லாம் முட்டை கேஸ் தான்ப்பா அவங்க எடுப்பாங்க நம்ம எதுவும் நம்மளுக்கு தெரியல ஒன்றும் தெரியல சரி திறந்து பார்த்துருங்கப்பா தட் மீன்ஸ் the medicine field always thought they were superior to surgeons, saying that okay, if the intellectual brain couldn't achieve it, let the surgeon finally cut in. I don't want the surgeons to be in that phase when AI is coming in. Let us not lose that opportunity that we are in the forefront of medical field. So I want to tell to every surgeon in this field, including Prof and Chief, sir, I may not be doing real surgery now. Maybe I'll be doing in another 3-4 years. There's a change in mind. But what I want to say is, let us not lose this opportunity, not only to further the branch of surgery, but to contribute to the field of medicine. We have got much more that we can contribute to the field of medicine than other fields of medicine because of both the mind and the hand coming together. And I believe that's my passion. Thanks for this opportunity.
Well said, well said.
Thank you, everybody. Thank you, AK, for staying right up to the end. And we'll
Thank
meet
you,
you
sir.
again. We'll meet you again next week with another episode of Marvelous Medicine. And I promise we will have AI in Surgery Part 2 soon. Till then, take care and stay safe. Good night.